Charles, what is the penetration of EHRs in U.S. hospitals?
This is a question that requires a rather diverse answer. The penetration in a large health system is extremely high, I would say 100%. But if you move in different areas, in the smaller hospitals and in the communities and the small rural area, the penetration is very low. So extremely disparate and depending on the care setting.
Elizabeth, what do you consider to be the key benefits of EHRs?
EHRs are pivotal in improving quality, reducing costs, increasing access to information for clinicians across the organization as well as beyond the walls of the organization to share patient information where patients see multiple providers in different locations. Test results are available much more quickly. There are alerts and information presenting to ordering clinicians so that orders are more complete. Drug interactions and allergic reactions are avoided because the clinicians are presented with that information as they're doing their orders. Overall, it will serve the healthcare delivery system to benefit from these increased efficiencies, increased access, and improved quality to, over time, reduce the cost to the system in general.
What are the barriers to market penetration, Charles?
Barriers are definitely the ability to deploy and host such a system. Different hospitals have different IT team that have different level of expertise, and for some of them they are well trained and well experienced in doing that, and for others it's a challenge and they need support. There are also barriers in terms of ability to finance the investment in EHR, and we are seeing rather large initiative by the federal government with a meaningful use in trying to subsidize and encourage and motivate and provide relief in that funding area.
So let's talk interoperability.
Yes, interoperability is and has been fairly significant barrier. Like Elizabeth was explaining, to justify an EHR just for your internal work, yes, it can be done. But very rapidly, especially in the ambulatory care, sharing information is the intrinsic part of the value of the EHR. And there we have seen a very fragmented approach, no state strategies, federal strategies that were not well organized until a few years. Now there is a lot of attention on interoperability and moving interoperability forward. This has become, an agenda all the way to Congress and the presidency and the Health and Human Services Secretary. So this is really now a priority in America, and we are really happy about this. And the association has been promoting, encouraging, and trying to foster this understanding.
What are the concrete strategies your association is deploying for that?
I would say there are probably three strategies that the EHRA has. The first one is a strong consensus among our members. And I vividly remember the first time the association was quite young, we brought together 30, 35 EHR vendors around the table and we say, now, can we get an agreement? Can we align? Can we make a proposal? Can we drive something together? And to my surprise, it took a couple hours to realize that we had a very solid agreement. We all were supporting, for example, efforts in the standards making with HL7, CDA. IHE was very prominent, and the adoption of IHE profile has been something that the association has supported for many years across its membership. So that unanimity is definitely the first element of our strategy. The second one is we want to allow variety but reduce unnecessary alternative. And therefore what we have been doing constantly is to say, if you transport information, we have a few basic use cases. Let's reduce the solution to what is needed. If you want to secure things, there may be 2 or 3 security level. Let's reduce things. Let's remove variety out of the system and let's bring our consensus. And we've been contributing over and over to the federal government, to the various initiatives that have been put in place, a very consistent message, and I think we've been quite successful. The third strategy is being ready to deploy, is to engage in testing, connectathon. You've seen the interoperability showcase at HIMSS. Almost half of our members that are actively engaged in deploying, and the other half, which are maybe a little smaller vendor, are actually supportive and saying, yes, we don't have the resources to do that, but we support this effort. So that last element of being actors, active actors, is also part of our strategy, and we are very proud of that.
So how does all this contrast with the situation in Europe?
I would say the contrast with the situation in Europe is actually not that big. Being involved in part in a number of European initiatives, I can say that the technical specifications and the standards being adopted, the profile being adopted, are very, very consistent. And this is encouraging, especially for the members of EHRA that are more global in scope. The area where there is a little bit of difference is when it comes to the coding of information. The US is heavily anchored in ICD-9, not yet thinking too much of ICD-10, although this is an ongoing significant debate. The move will happen. The question is when. We don't know yet. Coding of medication is very US specific. So those are the specifics, but they are a small part that is specific compared to the rest. In security and privacy, I would say we have the same situation than in Europe, a very confused scenery. A lot of debates, but in the end, when people are actually implementing, we are seeing less differences than there appear to be in the communication and in the acceptance. So I would say a fairly consistent effort. Maybe a comment which is more of a personal comment is it's quite hard for one country to listen and take advantage of the experience, success or failures of other countries. And this is something that we are discussing at times in the HR Association. Our members understand this, but this is still something that needs, I would say, more maturing to have that global understanding.